Thank you.
Thank you, Professor Zhou Jianping. And I have a question for you, Professor Mitsudomi, regarding your question in the last slide about do we need phase 3 trials for all targeted agents? So that's a tough question because the benefits in different settings may be different. For example, in the metastatic setting, the PD-1, PD-L blockers, they are very effective. But in the neoadjuvant setting, it seems that there are more patients got cured, and the benefits are bigger than those in the adjuvant setting. So in the metastatic setting, so if we move those targeted agents from end stage to early stage, so we have to compare with our parameter arm. Otherwise, we don't know. Would be because the standard of care in the early stage setting is either target therapy for EGFR or ALK, or chemo plus PD-1, PD-L1 blockers for those oncogenic driven lung cancers.
Yes. Yeah. So as you say that the effect of the target therapy is varies, right, depending on the genetic alterations and how good the drug is. For example, our rotenib is very nice, but the sotorasib KRAS is not so great. And we have the experience that the first-gen EGFR-TKI does not prolong the overall survival. So even though the first-gen TKI has some role to treat the patient with metastatic lung cancer, it's not so beneficial for the resected EGFR positive tumors.
Overall survival benefits, yes.
Right. So ideally, it's very difficult to determine whether the adjuvant strategy using the TKIs for any of the rare actionable genetic alteration is very difficult. But of course, the number of the patients are limited. You may have a lot of the patients in China.
That's a problem. That's a problem. The time needed for a trial for those rare mutations, that is much slower than the development of new generation agents. So that's the problem.
Yes. Yeah, I think that it will be very difficult. But probably, I think if you give the sotorasib after the surgery, it may not greatly improve the survival. So that's my guess. For the KRAS or the MET, maybe the effect of the inhibitors is smaller. Maybe ROS1, probably the adjuvant ROS1 inhibitor may prolong the DFS as well as OS. That's my guess.
Well, if you are asked to design a trial, for example, for ROS1 or KRAS in the adjuvant setting, so it would be the control arm. You choose chemo or chemo plus PD-1 blockers as the control arm.
Yeah, if you run the phase 3 trial, then the control arm should be the chemo alone, right? We don't know the chemo alone.
Yeah.
No immune. Yeah, but phase 3 trials itself will be very difficult. I mean, so that like in the LCMC 4 trial, like basket type trial, umbrella type. So if you have some patient has this mutation, then they give the respective inhibitors. So those are the single arm and with no control, but that's the only possible way to test the efficacy of these strategies.
In the metastatic setting, so for KRAS mutated patients, chemo plus PD-1 blockers is standard of care. So what's the reason that you choose chemo only as the control arm?
And now the KRAS inhibitors plus immunotherapy is being tested, right? So in the future, maybe KRAS inhibitors may come to the first line setting. So.
Oh, yeah. Okay. In the future.